So we're going to talk a little bit about technology, and the technology we're going to look at is actually photographs. And we all heard the term of the photograph is worth 1,000 words. Well, how about 2 photographs? And that's what we're going to talk about, stereo simultaneous photography. And the initial technique was using something that was called the Allen stereo separator, which you could set an angle on here and it would take a photograph in stereo. Now, when we're doing stereo photography, it was very important that depending on the size of the pupil, we would have a different stereo base. And SBS, stereo base separation, was very important because if your patient comes in today dilated like so and later on like so, and I moved the actual separator, you could actually look better one day, and the next time you came, you look a lot worse, and then which was true. So what was key is to come up with a technique of simultaneous. And Nidec produced a simultaneous film base, but as we all know, no more film, right? So we have to go towards technology that is more digital, and that is what Kowa introduced, a system that is extraordinarily versatile. And it's versatile because I can take simultaneous images digitally, or I can take a 45-degree field, full field. So I can take either or, 45 full field or stereo imaging. And that's a little bit what we're going to look at now. So we have these images. When we're doing simultaneous stereo, we're looking at a 20 by 27 angle of view. So we still get good nerve fiber layer and information in the optic nerve. Simultaneous stereo, again, comes only with a full dilation, so we need at least a good 3.8 millimeter to 4. But what happens once we start imaging below that, the images start having a little bit of shadowing, and eventually we start losing the image until we lose totally the image, but we still have one image. So stereo imaging for us is extremely important. So if I were to show you this full image and I were to ask you, what is the cup disc ratio in this patient? So you'd look at that and say, well, I have no reference point. So I'll do you a red-free, and you still don't have a good idea. So I'm going to produce a stereo with an emboss, and here we see it's a 0.9 cup. But the analysis that the Kowa system software has is we capture the image, and then we're able to actually analyze the image right there with the software, and it will produce a report that will tell us a little bit better what we're looking at. And here's the report. Now, why is that important? Because what we do at the University Hospital in New Jersey with Dr. Khoury is we do telemedicine. So we know that half the people that have glaucoma, diabetes, AMD, but in this case glaucoma, don't know they have the disease, have not been diagnosed, have not been to our office. So we actually physically take the equipment and we'll go to various centers and screen people. Images will then be sent to Dr. Khoury, who will then analyze, and Dr. Khoury is going to talk about that in a moment. But it's not strictly for optic nerve analysis. We could do also anything that has an elevation or depression and do those measurements. Once I take my stereo photograph, then I'll take a full 45, because I don't mind if I have a little bit of artifact. Every single image you saw here were of patients that are undilated, so we don't use dilation drops in the field. And we can do, of course, anterior segment, and I propose, if you have a moment, to go to booth 1646, which is Kowa, and take a look at these images. They're really, really cool. You get to see them in 3D, and you'll see stuff that you haven't noticed before. But what else do we do when we don't have access to 3D imaging? We'll take a full 45, and then I'm going to use a technique using filters that will produce an elevation or depression depending what the patient has. So if I were to ask you, are these elevated, or they depressed, or they flat, what would you say? Again, you might not have a reference point. So we create something in Emboss, and you can see this in strictly a filter. It's not stereo-based separation, but it gives us an idea, an illusion of what the topographical relief of the fundus looks like. It also has a mosaic in full 45-degree field of view, up to 8 images. So when we're doing our screenings, even though we say we're going to do a glaucoma screening, if a diabetic patient comes in and has a finding, we then record that and we send the images over in a full field. Now, what we've added to the program now is we will have an OCT with us, an OptiView OCT, hopefully early December or January, where we're going to have a much higher rate of success in the patients we send over to Dr. Khoury. So this is how we do our screening. As you can see, the one major difference perhaps from your office is all the screenings are done standing. And why do I do that? Well, I'm Canadian, so we have socialized medicine. We have to do things fast. But seriously, the reason I do that is because 40% of the time you spend with a patient is positioning the patient in. That's why you have your techs position your patients in the room and then you walk in, because that's what takes the most time. So we have all our patients stand and we capture images in that way. We capture the images. If the patient has nothing, we see them a year later. If there is something, we send the images up to a cloud, and then Dr. Khoury can look at the images from the cloud and then contact us back. I want to see this patient now or in 3 months or 6 months, depending what we're looking at. So stereo imaging is the first golden base that we use. The second will be autofluorescence. So we're looking at lipofuscin, especially in glaucoma around the optic nerve head. That will give us a good indication. And of course, the OptiView that we don't have yet, but hopefully soon, will be able to give us a full image. So when we send imagery over, then Dr. Khoury can come back to us and say, this is specifically what I'm going to do. The images are all kept in a file system, as you see here, and then we have direct live video feed from the physician that is reading the images off-site. One of the major difficulties we have in doing screenings is we can screen, detect, identify disease, and then we lose the patient. So in order to not have that, we have the direct contact communication affirming what we see and taking the action to be seen. So the screening is not, should not be looked at as, oh, the patient doesn't need to go see a physician. It's a screening program. We're just doing a dépistage. That's all what we're going to do to see what we have. And now Dr. Khoury is going to give you the clinical aspect. Thank you.
Thank you, Dr. George. It's a pleasure to be here. I do not mean to be anticlimactic, especially after the great Macish presentation, but I'm going to start by taking you back some 35 years or so to a paper by Dr. Lichter. I thought this was interesting because we're talking about stereoscopic imaging of the disc. And it was really difficult to find this paper. I had to go to the library, to the basement, to the paper editions, and then they were kind enough to scan it for me. What Dr. Lichter did in 1976, he had 16 glaucoma specialists evaluate stereoscopic and non-stereoscopic images of the optic nerve from glaucoma patients. And as expected, stereoscopic images did much better in terms of consistent reading, but they did even better when they looked at more challenging discs. When the glaucoma specialists were asked to rate pallor of the rim on sloped discs, for example, that's where stereoscopic images were much more consistent, and the chances of an inconsistent reading was reduced by almost 70%. So they concluded in this study 35 years ago that basically stereoscopic images were the standard of care. And if we basically go back to the American Academy of Ophthalmology preferred practice pattern from 2010, that is still the recommendation. So stereoscopic imaging is definitely a gold standard that has withstood the test of time. And the reason it's, like Professor Weinreb mentioned in his presentation, the reason it's very important to be critical in examining the disc is we have examples from multiple studies. This is from the ocular hypertension treatment study, where the majority of patients that converted from ocular hypertension to glaucoma did so based on optic nerve endpoints. And there are multiple studies that have concurred on this evidence. We do know from previous work that you can lose almost half of the optic nerve fibers before showing white-on-white visual field defects. Other studies have showed that the optic disc and the retinal nerve fiber layer damage often precedes detectable visual field loss. Again, Chris Johnson and his group, again, same theme, 80% of patients with ocular hypertension that converted to glaucoma had optic disc abnormalities at baseline up to 4 years prior to showing white-on-white visual field defects. And Professor Weinreb also touched on this, these tiny splinter hemorrhages on the disc, which could be very elusive, very difficult to detect. But basically, stereoscopic imaging of the disc is the best way to show these hemorrhages. From the ocular hypertension treatment study, they went back and they reviewed the images for hemorrhages. And in 123 participants, they had the hemorrhages. Strikingly enough, only 16% of those were picked up on clinical examination, while the majority, 84% of the hemorrhages, were picked up later on upon reviewing stereoscopic images of the optic nerve. What about how does stereo imaging compare to newer technologies? This is a paper from Chris Gherkin and his group. And they looked at stereo photographs and discriminating between glaucoma and non-glaucoma eyes. And they compared stereo imaging to the best parameter on HRT2, GDX VCC, and the Stratus OCT, the older OCT. And stereo photographs basically had the largest area under the receiver operating curve, which is shown here in this graph. So even compared to quantitative imaging, stereo photographs still do pretty well. Kowa has a new camera, 3D. It's a non-med camera. We've had it for the past few months. And we've incorporated into our telemedicine program. This is a summary of our experience with it. This summer, over 100 patients. Relatively young, mean age was 45, but the majority of patients were of African descent and had darkly pigmented iris color, which makes it a little bit more challenging to image non-mediatically. And the time to, in telemedicine, it's, we need to streamline a large number of participants in a short period of time, so it's critical that this the imaging streamlines quickly and as efficiently as possible. And that applies also in the office. So stereoscopic images were possible in both eyes in less than a minute in all of the subjects that we've imaged. And non-stereo 45-degree images were possible in less than 20 seconds. We evaluate the images off of a monitor in a standardized according to a standardized protocol that we've published earlier. We use a stereo viewer that allows you to fuse both channels of the image. And the advantage the Kowa has with its simultaneous stereo imaging is the fact that the stereo base is fixed and is consistent every time you acquire an image. So the quality of the stereo is going to be consistent all the time. The images are digital, so you can apply different softwares to analyze them. This is the software that comes with the camera. We're still studying the software. And the reason I wanted to show this example, this was an image that was where the cup and disc contours were marked by a medical student on a single channel, not on a stereo image. And then realigned after looking at the image in stereo. And you can tell the advantage of looking at the image in stereo, where aligning the disc and the cup contour was much more accurate. We've used software in our work to analyze optic nerve parameters for glaucoma during telemedicine, and it's definitely has a huge advantage. This camera, the Kowa, comes with its own software that has a newer way of analyzing images. This is a paper by Dr. Nakagawa where they basically looked at depth analysis of the optic nerve head using the stereo image pair. And the way this works is pretty complex. It's beyond the scope of what I'm going to talk about tonight, but in brief, you have two images that are separated by a stereo base, and a coordinate system is arranged along the optical axis of the left image and the right image. And each point on the image is assigned a 3D position according to the disparity that it forms, the angle that it forms against the optical axis of the right and the left channel. And this image is from the same paper where a depth map was reconstructed for the optic nerve head and compared to HRT2 depth maps, and the correlation was pretty high. This is from Kowa's software. It does give you a depth distribution of the optic nerve head after you line up a contour of the disc and the cup. And those are two examples from normal and glaucoma eyes. It also provides different stereometric measures of the optic nerve head. We continue to assess the software. It's still under study. So to sum up, I know dinner is ready, so I'm going to be short. Digital imaging is definitely superior to documenting the optic nerve head appearance by sketches. This is actually from a chart from one of our clinics. So you definitely do not want to document the optic nerve head like this. I would choose something like this. But the advantage of stereo imaging is not just documenting the optic nerve head appearance at one point in time. It's definitely helpful in detecting progression, like in this patient with pallor and thinning of the temporal rim. And this is another patient that we recently saw that had loss of inferotemporal rim 1 year apart, with the visual field not picking up that change until a year after. So to conclude, careful examination of the optic nerve with stereo images may reveal glaucoma and early glaucoma progression. And as technologies continue to evolve, as we've seen tonight, both in hardware and in software, it becomes hard to follow up patients with a chronic disease like glaucoma over time when the platform is constantly changing. And someone just asked this evening whether you would wait to acquire the new technology or you would go take the plunge now. And I think that's where the advantage of stereoscopic imaging lies. It is an enduring technology. It's been with us for decades, and I think it will continue to be with us for some time. Thank you.